Hello, I'm Dr. Faith Ottery. I'm extremely pleased to collaborate with the Clinical Oncology Society of Australia Nutrition Group to deliver this instructional series on the Patient-Generated Subjective Global Assessment, or PG-SGA. Originally developed in 1994, the PG-SGA has come to be considered the gold standard for nutritional assessment and malnutrition diagnosis in oncology, and is widely used in other chronic catabolic conditions. It is a validated tool that supports the identification of nutritional risk and formal diagnosis of malnutrition and assessment of its severity, while also guiding clinical decision-making and proactive multimodality intervention. Welcome.
The PG-SGA is primarily used as a comprehensive nutrition assessment tool. However, it is a 4-in-1 instrument that can be used for malnutrition screening, nutrition assessment, as an instrument to monitor interventional success, and for triage purposes. It supports efficient clinical workflow and communication across care teams while enhancing the quality of clinician-patient interactions. This module is focused on completing the PG-SGA in its full form as a nutritional assessment tool. Conducting a formal assessment and diagnosis of malnutrition or undernutrition is essential for guiding clinical care proactively. It may also influence funding decisions or service delivery in some healthcare settings. The PG-SGA yields a numerical score and a global rating of nutritional status. The scoring system integrates patient-reported concerns with clinical indicators of nutritional risk, severity of deficit, and prognosis, and to support targeted nutritional intervention and triage. Although the numerical score and global assessment category are related, they are independent triage and assessment systems. In general, the higher numerical score, the higher the nutritional risk, and the greater the need for nutrition intervention. The PG-SGA was designed in the context of an integrated paradigm known as anabolic competence. For more detail on this, refer to the Frequently Asked Questions section of the How-To Guide. The PG-SGA is recommended in a number of international evidence-based guidelines and is available in more than 20 languages in both PDF and web-based versions. The PG-SGA has two main sections. Boxes 1 to 4, also known as the PG-SGA short form, are designed to be completed by the patient and collect information on weight change, food intake, nutrition impact symptoms, and physical function. The PG-SGA short form is a validated screening tool and can be used as a patient-reported outcome measure. Worksheets 1 to 5 are completed by the clinician, such as a dietitian, doctor, nurse, or therapist, with the patient's input. These sections capture conditions that increase nutritional risk, metabolic stress, the nutrition-focused physical examination, and the clinician's global assessment based on the consolidated score. Information from both the patient and clinician-generated sections contribute to the total numerical score. This supports the clinician's determination of nutritional status and malnutrition severity, or when used proactively, the patient's risk of malnutrition. We will walk you through how to complete and score each section of the PG-SGA. Box 1 captures the patient's weight history, including current weight, weight change during the past 1 month, 6 months, and whether weight during the previous 2 weeks has decreased, not changed, or increased. Refer to Worksheet 1 for scoring weight loss. Using the weights provided, calculate the percentage weight change. Use the 1-month weight change for scoring where possible, as this lets you better understand the impact of intervention or progressive disease, while the 6-month data helps you understand the degree of chronic depletion. There will be times when weight is influenced by fluid shifts, edema, ascites, or corticosteroid use. This should be taken into consideration. Scoring for Box 1 is additive. Add the points calculated in Worksheet 1 to any points recorded in Box 1 for the weight change in the past 2 weeks. Record the total as the Box 1 score. Box 2 assesses the patient's food intake over the past month compared with their usual intake. The patient reports whether their intake over the past month is unchanged, that is, stayed the same, or whether it is more or less than usual. If their intake is less than usual, they should select the most accurate description from the options listed. Scoring for Box 2 is not additive. Record the highest score selected in Box 2. Box 3 assesses symptoms that have negatively impacted food intake, absorption, or utilisation of nutrients in the past 2 weeks. The patient indicates which symptoms have directly impacted their food intake during the past 2 weeks. Symptoms do not need to occur daily to be counted. If they were present at any time in the past 2 weeks, they should be scored. What matters most is how the patient experiences their symptoms, not what we as clinicians think is contributing. For example, pain that isn't well controlled, no matter where it is, can reduce a patient's food intake simply because it stops them from getting up, walking to the kitchen, or preparing a meal. If there is a significant symptom or symptoms such as depression, dental problems, or food insecurity impacting nutritional adequacy, include these as other. As for Box 1, scoring for Box 3 is additive. Add the points for all relevant symptoms selected and record the total in Box 3. Box 4 assesses the patient's activity level and functional capacity over the past month and is based on a patient version of the Eastern Cooperative Oncology Group, or ECOG, performance status. The patient selects the single option that best describes their usual activity and function over the past month. Score reduced activity regardless of the underlying cause. Any reduction in activity is relevant, as reduced activity is associated with loss of muscle mass and functional decline. Scoring for Box 4 is not additive. Record the highest score selected in Box 4. Boxes 1 to 4 are scored by the clinician using the following rules. Boxes 1 and 3 are additive. Add all points within each box together to determine the box total. Boxes 2 and 4 are not additive. Record only the single highest score selected for each box. Note that both the additive boxes are on the left-hand side of the form and the not additive boxes on the right side. This makes it a bit easier to remember. Add the final scores from boxes 1 to 4 and record the combined total in Box A. Worksheet 1 is used to determine the percentage weight change score for Box 1, which contributes towards the score in Box A. Worksheet 2 identifies conditions that may increase nutritional risk or nutritional requirements. Tick all relevant conditions. Scoring for Worksheet 2 is additive. Add 1 point for each condition identified. Add all points and record the total score in Box B. Worksheet 3 assesses metabolic stress, such as fever and corticosteroid use. These variables can have a significant impact on nutritional status and are often overlooked as catabolic stress. This is important when considering increased protein requirements, as well as increased lean tissue or muscle catabolism. For fever, score either the intensity, that is how high, or duration, that is for how long, whichever is greater.
For a list of prednisone equivalents, refer to the accompanying how-to guide.
Scoring for Worksheet 3 is additive. Add all relevant points and record the total score in Box C. Worksheet 4 captures the results of a nutrition-focused physical examination, which is required to make a malnutrition diagnosis and to help determine severity. For details on how to complete the physical examination, refer to Module 2, PG-SGA physical examination. Evaluate multiple sites to inform an overall clinical impression of skeletal muscle status, fat stores and fluid status. Ideally, evaluate as many sites as is practical. Each aspect of the exam is rated for degree, that is 0, 1+, 2+, or 3+. Ratings for individual sites are not additive and are used to clinically assess the degree of deficit for muscle and fat and presence of excess fluid. So none equals 0, mild equals 1+, moderate equals 2+, and severe equals 3+. Using clinical judgment, determine the overall subjective rating of total body deficit, noting that muscle depletion takes precedence over fat loss or fluid excess. Scoring for Worksheet 4 is not additive. Assign an overall subjective rating of total body deficit based on the global assessment. To score, record the points, that is 0, 1, 2 or 3 in box D. The PG-SGA provides a numerical score. The total numerical score is calculated as the sum of boxes A, B, C and D. The higher the score, the higher the nutritional risk and need for intervention. The numerical score can be used to help triage nutrition intervention. A score of 4 to 8 indicates the need for intervention by a dietitian. A score of 9 or more indicates a critical need for improved symptom management and/or nutritional intervention. Worksheet 5 captures the clinician's global assessment of nutritional status and is used to determine a malnutrition diagnosis and its severity. The global assessment integrates information from the patient-reported sections, clinician worksheets, and the nutrition-focused physical exam. Assign the overall global PG-SGA category as either Stage A, being well-nourished, think of A for anabolic, Stage B, which is moderately malnourished or suspected malnutrition, or Stage C, which is severely malnourished. Think of C for catabolic. The global PG-SGA categories, A, B or C, are used to determine nutritional status and malnutrition severity. The numerical PG-SGA score provides additional context but does not correspond to specific numerical thresholds for assigning the A, B or C category. The global assessment is based on clinical judgment, an overall interpretation of the patient's current nutritional status, including whether the patient appears stable, improving or declining. To assist with assigning the global category, it may be helpful to circle A, B or C for each category as you work down the list. The global status corresponds to the column with the most circles. The assessment is subjective. With practice, the global assessment becomes routine, more accurate, and can be completed efficiently within clinical workflows. Record the PG-SGA score as follows: PG-SGA numerical score, then global category, followed by a description of that category. For example, PG-SGA 13, category B, which is moderately malnourished, as evidenced by 3% loss of body weight in 1 month and mild muscle deficit. Additional clinical detail may be included as appropriate, such as nutrition impact symptoms, recent intake changes, diagnosis or treatment context. Sites using structured nutrition diagnosis frameworks, for example INDT or PES statements, may document the PG-SGA findings within their usual documentation system. This concludes our instructions on how to complete the PG-SGA.